last session, and today we are going to have another session on gastrointestinal symptom, which occurs in patients not very rarely, but uh, it's you can see in some patients. Uh, so when there is intestinal obstruction, it indicates an advanced disease in many patients. And what happens? The management of intestinal obstruction usually will be nilper oral, nasogastric tube aspiration, and maybe if the intestinal obstruction is so advanced, the patient will die of intestinal obstruction. And when the family look back, uh, they will see that their loved one died even without having little water. That's what they remember. So let's hear from Sreedevi what else can we do to comfort the patient and uh, so that the families will have a better experience. So as as we have already introduced Sridevi in the last session, she is a palliative care physician in Pallium, India, and she has done her MSc in palliative medicine from Cardiff University, and has been working in palliative care for more than 5 years. So welcome Sridevi, and it's over to you.
Thank you, sir. Sir, I think we have left behind constipation also. So I'll be taking constipation as well as bowel obstruction today. And thank you all for joining us again. And last week we have dealt with one end of the alimentary tract, and today we will be going to the other end by talking about constipation. And a post lunch session and talking about constipation is really funny, but yeah, we have to learn about constipation. Um, Arun, the screen is visible, right? The PowerPoint.
Yes, ma'am, it's visible.
Okay, thank you. So this is a typical constipated bowel. Everyone is fighting in between. Everyone wants to move forward, but some people are really hesitant to move forward until they receive an apology. So what today we'll be dealing mostly with what is constipation and why should we learn about constipation specifically, because we don't really take it as a major symptom, and what are the causes and how do we assess and how do we manage constipation. So, what is constipation? It is very subjective, I must say, but it is a frequent passage of small volume of feces infrequently and with difficulty. So, it is not just not passing feces, but if someone is passing motion or fecal matter with difficulty, that is also considered as constipation. And you can see the sentence: it is persistent, difficult, infrequent or seemingly incomplete. After the bowel opening, the patient may not feel that he had or she had a complete defecation. So, that is one other description that patients will tell you. And this is one of the very, very common symptom that you find once you start asking. Until and unless you start asking about constipation, you may feel that constipation is not a major symptom. But once you start asking, you will feel that I think much more than pain, patients suffer from constipation, and it is a most mismanaged symptom that I am very sure about, because first thing, the patients will not come to you, very rarely they come to you telling that I have constipation. First there will be embarrassment. Second thing, you can see the first misconception is that diet. Everyone, literally everyone, including physicians and nurses, believe very strongly that until and unless you eat, you will not have a fecal matter, solid fecal matter. So it is okay. You are not eating, no bowel opening. It is expected. That is the biggest misconception, and that you need to focus from now onwards at least. It has nothing to do with the diet. Of course, it has to do with the diet, but even if the patient is not drinking or eating, we know that how the fecal matter is formed, what is the content, and there has to be proper bowel opening. And what are the psychological factors? When you're admitted in a crowded hospital in a general ward where there is no screens in between, very often in a government setting, especially, privacy is a big thing. Even when we are traveling, many of us don't like to go to a public toilet or anything. And instead of that, we try to control the bowel opening. So privacy is a very big issue, and patients, many of the patients will be on the ward for a long period of time, not just 1 or 2 days. So privacy is a big issue. And bedridden patients, what we do, we give a bedpan. I don't know how people manage to have a bowel opening in the bedpan. The position is really awkward, and the privacy, the clothes will be removed, and we'll be more concerned about the person lying on the next bed than having a bowel opening. And second thing will be loss of control. If I have incontinence, I prefer to be constipated, because then there is no issue for the caregiver to clean me or wipe me, because I don't want anyone to wipe my ass, obviously. So that is one psychological issue which can lead to constipation. Overlooking the side effects, we think it is okay not to have a bowel opening. It is okay, I'm comfortable, I don't have any issue, I'm not eating also. So we are overlooking the side effects. Suboptimal use of laxatives. The moment you prescribe laxative, when you write morphine, people are really worried about the loose stools, because already I am debilitated, I can't go to the toilet on my own. What if I develop a diarrhea? No one wants to have a diarrhea. So even if you tell them that morphine can cause constipation, that is why I am writing laxative, they'll be slightly worried about having a loose stool episode. So what they do, generally they take suboptimal use of laxatives. And some of the physicians don't think that constipation is a major issue, so we tend to write a suboptimal dose of laxatives. And sometimes they come with atypical presentation, and we don't think it can be due to constipation. Sometimes they tell you dyspepsia like symptoms. They very often they come with urinary tract infection and delirium, and they may not tell you firsthand that I have a constipation issue, but they come up with all these issues. And very common misconception, overflow diarrhea. Patient come to you with diarrhea, and we treat diarrhea. But why this diarrhea? We don't ask or inquire too much about it, and the patients will tell you that I have a loose stool, which is true because they have an overflow diarrhea. So this is the Rome criteria used to determine whether a patient is constipated or not in a clinical setting. So they have to, at least two or more of the following criteria should be satisfied. First thing would be straining during at least 25% of the defecations, a sensation of anorectal obstruction. So first thing, straining and feeling of obstruction in the anorectal region, lumpy or hard stools, and fewer than three bowel openings per week. I'm sorry about the background now. So these are the Rome criteria for understanding whether the patient is clinically having a constipation or not. At least two or more of the following should be positive. For this, we have to ask in that way. We have to ask specifically what is the consistency of the stool. They may tell you that I have a proper bowel opening. You have to ask whether it is lumpy or hard stools. How many times a week you are having a bowel opening? Do you have a feeling of obstruction? Do you have to strain a lot when you go to the toilet? And in advanced disease, what is the problem? You have a constipation and you have an advanced disease. It can cause colicky abdominal pain, and many of the people don't eat. Already they have anorexia, and along with that, constipation can aggravate the existing eating issues. I don't want to eat because I didn't have any proper bowel opening. It can cause nausea and vomiting, a prolonged period of constipation. Last week we heard how it can cause nausea and vomiting. Very often people come to us with urinary retention, and while examining and while taking the history, we ask specifically about bowel habits. Then we come to know that patient was having a constipation for a long period of time, which has led to urinary retention. And especially in elder people, or especially people who have had a proper bowel opening for a long period of time, suddenly they stop having that habit, they'll become more anxious. But usually the caregivers will not be that much bothered, because they always relate that to the diet. Especially in cancer patients, the intake will be very less, so they think that anyway I'm eating only gruels or soups, so only liquid diet, so I'm having a lot of urine output. No, it is okay to have constipation. In elderly patients, there is a very close association with any change in the regular activity, but constipation has a major impact. It can cause confusion and delirium in elderly. Sometimes they come with only with delirium, and after taking history only, we will come to know that the constipation was the major issue behind the delirium. So what are the causes? We know that many of the drugs that we use, like antacids. Many of the antacids can cause constipation. Antiemetics, like last week we explained about the ondansetron. Ondansetron has a constipating effect. Anticholinergic drugs, many of them we use for prevention of vomiting, again can cause constipation. Many of the anti-epileptics that we use as an adjuvant medication for pain can cause constipation. And we use opioids. Opioids are known to cause constipation. Antidepressants, many of them, and many of the antipsychotics. So, what are the metabolic causes of constipation? We know that patients will be mostly dehydrated, and last week we explained about hypercalcemia. So, when there is hypercalcemia, there will be severe pain and there will be nausea and vomiting. So, along with that, there can be constipation. Hypokalemia, again, known to cause decreased bowel movement and uremia. So these are the metabolic. All of these are not rare at all. We always see them. It's not a rare thing that we come across, but it is, I think, one of the symptoms that we come across on a daily basis. Neurological causes, we know that when there is a malignant spinal cord obstruction at later stages, patients will have a constipation and urinary retention or any tumor infiltrating the sacral nerve. So what are the structural reasons? We know that any tumor, any pelvic tumors can cause constipation, or any anorectal condition, any anorectal tumors or infiltrations. And after post-RT fibrosis can also lead to constipation. Depression, when you explore more about depression, one of the main symptoms of depression, along with anhedonia or fatigue and everything, we know that depression, we have constipation very strongly associated with as a symptom. Diets, we know that patients don't drink or eat much of the fiber, and we can't insist patients to have fiber so that you will have a good bowel opening, because most of the patient population in palliative care, they will not be able to have good fluid or fiber intake. Many comorbidities like hypothyroidism and diabetes can also cause constipation. And most of them, they'll be confined to bed or to the chair. They won't be going out of the home. So there is very, very less activity. So that is another reason for having constipation. They might have been active in the past, and we know that it is mandatory to have some physical activity to have a normal bowel opening. So in our patients, the immobility or inactivity is they are the other reasons for having constipation. Inability to obey the call is very, very important. We tend to ignore that, but many of them will be dependent on the caregivers to go to the toilet. So suppose when they want to go, the caregiver might be in the kitchen, or the caregiver might just gone to have a sleep after a long period of caregiving. So then they don't want to call them or don't want to bother them, and they may not be able to go at the time where they want. So that inability to obey call or when they are coming for radiation or chemotherapy or to a hospital, they may not be able to go get up and go in between the treatment. So that is one important thing that we tend to ignore, or we just don't ask all these fine issues. So in palliative care patients, we know that opioids are the culprit in terms of constipation, and dehydration is very common in our patients. As we mentioned, reduced mobility, hypercalcemia, many neurological deficits, not just in cancer, many other neurological issues. When we see the spinal cord injury patients, you know that there will be a lot of things, including constipation management to be taken care of. And the drugs used in palliative care, anticholinergics, antiemetics, and some of the antacids, which will have more of aluminum salts. So how do morphine cause constipation? You might have heard about this during the morphine session, but I'll just mention the points. It will reduce the propulsive intestine. So the propulsion is reduced and it increases the non-propulsive activity. So altogether, the propulsion is completely reduced. And so there will be more time available for water reabsorption, so the stools become really hard. And less fluid enters the gut also. And morphine has an effect on rectal, it reduces the sensation of rectal distension. So they may not feel that the rectum is full and they want to have defecation. So it can cause fecal impaction. So what should we do? in our setting, especially when we go for home care or in the inpatients, after you ask about the pain, the next question is definitely about the bowel movement. So these are the questions that we usually ask for all the patients, invariably every day, everyone. When did the patient's bowel last move? So they may tell you, today morning I had a bowel opening. Don't stop there. What was the consistency, size, and volume? Was it adequate? Was it leaking or diarrhea kind of bowel opening, or was it too hard and lumpy stools? Was there any blood in the stool? What was it a black colored stool? And how easily you could pass the stools? Did you have to strain a lot? And do you feel satisfied after having a proper bowel opening, or is there any sensation of incomplete emptying? Some signs of fecal incontinence, like you are unable to sense that you had a bowel opening, or overflow. Do you always soil your clothes? Like when they say diarrhea, we specifically ask that question: is it large quantity diarrhea? What is the color, or is it like leaking? So a frequent soiling of clothes, so we can differentiate whether it is an overflow diarrhea or a frank diarrhea. So these are the mandatory questions asked by every single nurse and doctor in our setting. After the pain charting and everything, these are the questions that needs to be asked. Then you will understand how frequently you will come across patients with constipation. Almost invariably, almost everyone will have something or the other issues with the bowel opening. So this is a Bristol stool chart. I'm sure you might have seen this chart. So if you're unable to ask what you're supposed to ask, like hard lumpy stool, sometimes we may not be able to translate it in our language that they understand. So you can take this picture in the mobile when you are in a home care setting and just ask whether they can relate, or if the patient is unable to express, then it is better to ask and see whether there is a constipation or even the diarrhea. So you know that the type 1 to 7. So this picture is easy to relate. The patients will tell you, okay, it was like this. Or the caregiver will tell you, while cleaning, I saw hard lump or nuts or nuggets kind of stools. And if you think that the patient is constipated, I think pain is one symptom that we have to believe the patient. We are talking from the class one, most probably, about believing the patient. I think constipation is one symptom that I wouldn't believe the patient at all. I wouldn't believe the caregiver at all. Because the moment you ask about constipation, everything will seem all right. They will say, I don't have constipation. But when you start asking questions, when was the last bowel opening? No, he's not eating. He's having just juices and soups. So it is maybe 2 to 3 weeks. When you start asking, that will be the first response, 100%. No eating, just drinking fluid, so no bowel opening. And so never trust them when they say they don't have constipation. So keep asking them. Check the oral cavity, check whether there is any dehydration. And physical examination of the abdomen is very important. And even in bowel obstruction, we'll come to that next session. Bowel obstruction, it is very important to have an abdominal examination and listen to bowel sounds. Rectal examination is one thing that literally makes me satisfied, because even if they think that they are not constipated, very often, very commonly, most often, I must say with confidence, that rectal examination, you will know that the patient has been constipated for weeks. So I try to it's not a pleasant thing to do. Maybe I wouldn't want for myself to do a rectal examination, but definitely we tell the patient, convince them that there can be constipation from what you are talking about, your bowel habits. So we'll try to examine the rectum and see, because if the fecal matter is impacted, the 1, 2, 3 consequences, and tell them that fecal matter is not just food. There are many other ways from the body which needs to be eliminated. So that is one information that you need to give them. And if needed, you can take an abdominal X-ray. Very rarely needed. The moment you do a PR examination, you will come to know whether the general bowel issues. Rectal examination is not at all a pleasant thing. So before doing that, I'll explain the patient what am I going to do. I'll do it as gently as possible. I use plenty of what our nurses usually do it. They use plenty of lignocaine. They tell the patient to relax and take breathe through the mouth, and we make it as comfortable as possible and as gentle as possible. So it is very important to explain what you're going to do rather than telling the patient lie down on your left side and just inserting your finger. That is not at all acceptable. Explain to them what you're going to do. So during rectal examination, I know that I don't need to tell you all these things, but it is just a reminder for everyone. If the rectum is empty and collapses, it indicates a functioning bowel. So when you put the finger, if it is just lying around your finger, just holding your finger, then it means that you have a functioning bowel. If the rectum is empty and dilated, which is very, very common, you feel a lot of space around your finger, or a balloony rectum, we say, it indicates that the fecal matter is high up in the bowel. If it is balloon, it is having we can assume that the patient was having constipation for maybe weeks. And if there is fecal matter in the rectum, try to understand whether it is soft or hard and manage accordingly. If it is soft, you may not need aggressive measures, but if it is hard, you may need to evacuate digitally and then give a suppository or an enema. And check whether you are touching a tumor or the fecal matter. If the surface is irregular, hard, and check the tip of your finger after doing a rectal examination, whether it has a blood or any other secretions, any other color change, or it is a fecal matter. So always check the gloved tip of the finger and what it tells you. Every small step is really important. Prevention, the hand that charts morphine should chart the laxative. The moment you write morphine, the next drug should be a laxative. And what laxative, we will come to it. Non-pharmacological measures, we know that daily assessment is the key. Every time you see patient, you have to ask about constipation. They will tell you pain, they will tell you nausea, vomiting, or sleeplessness. Everything patient will tell you voluntarily, but constipation, you have to probe. You have to probe a lot. So daily assessment, every single visit, you have to ask and you have to document. Improve mobility as much as possible. They may not be able to walk, but on the bed, if we can move the limb movements, passive movements we can give, that is better. Access to toilet in our setting, especially in Kerala, I think it is the same thing in the any rural places. Access to toilet, the toilet will be outside the home, or I think in the northern parts of India there may not be a toilet even. In Kerala, thankfully, we all have a toilet at home, but usually it is outside the home, or very commonly steps. They have to climb up, then they have to take a right turn, and they have to enter into someone else's room, and then again one more step, and then go to the toilet. So access to toilet facility is a very important thing. And if I don't have access and I need a person to carry me to the toilet, I prefer not to have a bowel opening. Rather, I should be on my way. So in those cases, try to provide a small commode chair. Commode chair is not that expensive. It is available in the plastic chair form. You can just, it hardly costs anything. So if you are able to provide a commode chair so that the patient can have bowel opening inside the room, there will be enough privacy and there will be enough toilet accessibility. Prompt response to patient call is one thing we can do, but especially in our hospice setting. But at home, there will be only one caregiver, and that is slightly difficult to manage. Privacy is one thing that we need to ensure. Diet and fluid intake, I won't emphasize much because patients may not be able to drink and eat what they want to, or what we prefer to have, like high fiber diet and all. Attention to other symptoms. Ask for urinary retention, urinary difficulty in passing urine, confusion. So give attention to other symptoms also. So classification of laxatives, we have a small classification for laxatives. The key is to write the appropriate laxative. Last week, we were emphasizing on the appropriate antiemetics, and today we are talking about the appropriate laxative. It is not just giving a cremafin syrup, or the most commonly used laxative would be lactulose. So when you are writing a lactulose prescription, you must know how it is going to act. What is the reason for constipation? Is lactulose the right the laxative to give? So it's not a universal prescription for everyone. So these are the major class of laxative: bulk forming laxative, softeners, osmotic laxative, stimulant laxative, and some of the other laxatives which is not primarily laxative, but it can help in initiating bowel movement. So bulk forming laxative, you might be using that in other setting very commonly, but not normally used in palliative care patients, because they're already debilitated and they can't drink extra fluids. And I don't think it is pleasant to mix this powder in water and drink and to give the bulk. I don't think that is a pleasant thing that especially a palliative care patient would want to drink. That would be the last thing to have. So it's not very commonly used in palliative care. Osmotic laxatives are lactulose is an example for osmotic laxative. It has non-absorbable sugars and it has an osmotic influence causing water retention in the lumen. It can cause some amount of cramping and nausea, but not very profound. It can cause dehydration also. But there are some illnesses where you have to prescribe lactulose, where you need, because it has an action on the gut bacteria. So there are situations where you need to give a osmotic laxative. We know that the liquid paraffin is a softener which can be used to soften the stool. It cannot be used alone because there is no point in softening the stool. It needs to be it needs to go out, right? It is not just about softening the hard stools, it has to come out. So always better to combine with a stimulant laxative. So it's simple logic. Ask the patient whether the stools are really hard and lumpy and not like stools. That means they need a little bit of softener so that the stool is not that hard and lumpy. And ask them whether they have to strain a lot when they go to the toilet. The consistency is fine, the fecal matter is fine, not too hard, but I can't it is not just coming out. I have to put a lot of strain. So then they may need a stimulant laxative. The most commonly used stimulant laxative is bisacodyl in our setting. It has a direct action of myelinic plexus and submucosal plexus. It has a sometimes patient do tell you about a little bit of colicky pain after they take bisacodyl. So then you have to be a little bit cautious. It should be avoided in a complete obstruction patient. So this is the steps. You can start with 10 milligram HS plus or minus softener. So if the patient already had constipation and I am starting the patient on morphine, so then I would add a softener in the first visit itself. Or if the patient is okay, no constipation history at all, and I'm starting morphine, I would start with only stimulant. And on next visit, after asking, if needed, I will add a softener. So first step would be 10 milligram HS plus or minus softener. And again, constipated, you can slightly increase. A maximum would be 30 milligram a day plus or minus softener. The most common softener we use is crimafin, and you have to be called, like some crimafin has a stimulant. For example, crimafin plus has sodium picosulfate also. But I think always I add bisacodyl because it has more stimulant action. Rectal measures, sometimes we need to do manual removal, and after doing parental examination, either remove manually or keep suppository. If the rectum is balloony, if there is a lot of space around your finger, normal enema will not work because the fecal matter is impacted high up in the bowel. It is a high up impaction. You give the enema from the periphery, nothing is going to affect. So you have to use a high up enema. Sorry. So you have to use a high up enema. How to give a high up enema? We usually use phosphate enema. It has a slight osmotic action also. So we attach the suction catheter or red rubber catheter, whatever catheter is available in your setting. Some settings they use red rubber catheter. We use suction catheter, the smaller size, or the Nel cats you can use. Attach the enema to the tip to the one end of the catheter or suction catheter. Put lot of jelly, lignocaine jelly, and gently insert the suction catheter till the point you feel obstruction. So as much as possible up. So you are actually bypassing the impacted fecal matter and you are administering enema there. So that is how we should give high up enema for fecal impaction. The high up enema is not a practice in the regular setting. I think only in palliative care, people use it very regularly. When you feel that the rectum is balloony, this is the best way to manage that because the fecal matter is impacted high up in the bowel. There is no point in giving a low enema. So you have to give a high up enema. Spurious diarrhea or overflow diarrhea. Very commonly, patient comes to us telling that I have diarrhea, so I stopped taking laxative. I have prescribed laxative, but doctor, I have diarrhea for more than 3 days, so I stopped the laxative. And one doctor nearby told me to take loperamide also to stop the diarrhea. So what is going to happen? So first thing, the patient tells you that I have loose stool. Ask them when was the last bowel opening, because there will be a prolonged period of constipation just before the diarrhea. So that is very important question. The moment you hear diarrhea in palliative care patients, ask when was the last bowel opening. And as I said, don't trust the patient. Do a rectal examination if possible, and digital evacuation followed by regularization of laxative. So you have to tell them why the spurious diarrhea occurred, why there is leaking of uh, fecal matter is happening. Accordingly, you have to tell them and show them, and then tell them to regularize the laxative. So it is not a symptom. It is a symptom, not a disease. And if you don't give the laxative, it is not going to work at all. So you have to prescribe laxative. And the palatability vary from patient to patient. Some people are okay with taking crimapin, some people don't like, so then we have to give a lactulose. But generally, you need a combination of softener and a stimulant. So that is about constipation. I rushed slightly, but because we have to deal with bowel obstruction, we'll take the questions in the end after the bowel obstruction. Uh, so we know that we deal with a lot of bowel obstruction in maybe in your practice, but today we'll be dealing with signs and symptoms with a radiographic evidence and causing the obstruction of passage of the GI contents. A cancer and anti-cancer treatment related. That is the most common scenario that we come across in bowel obstruction. It's a very difficult area. There is no single strategy that can work as in any other symptom like nausea, vomiting, or constipation. But there is a considerable variation in symptoms. A patient present with wide variety of symptoms, and approach to management is also varies from patient to patient. It is, as Dr. Sunil was mentioning in the introduction, it is very commonly seen in advanced stages of cancer. Once the patient is diagnosed with bowel obstruction, generally the median survival is 1 to 3 months. Sometimes they present with bowel obstruction and then they get diagnosed with cancer. But the survival, it is a very, I don't know how many oncologists are there in the group, but I think this is what they also will agree. It's the survival is less. Then it can occur anywhere from esophagus to rectum, and very commonly it is seen in small bowel. Most commonly seen along with gynecological cancers and then followed by colon cancer. Very rarely we can see bowel obstruction in other cancers also, like breast, gastric, lung, and pancreas. So these are the different types of obstruction: mechanical or functional obstruction, partial or complete obstruction. There will be obstruction at a single site or in a or multiple site obstruction. It can be intraluminal or intramural, where there will be infiltration of intestinal muscles. Extrinsic, there can be obstruction from outside, as mostly seen in gynecological cancers. The GI tract is obstructed from outside. Many of the times it can be due to treatment related obstruction, either additions from surgery, desmoplastic reactions to chemotherapy, not really rare. It is also very commonly seen. Torsions, I have not seen much due to torsion. Internal hernia is another reason for having bowel obstruction. Very rarely there can be pseudo obstruction. So all the symptoms and signs very well relate to obstruction, but it's a pseudo obstruction because of the destruction of enteric neurons. And some of the drugs can cause severe ileus, which mimic symptoms of obstruction. And diabetic neuropathy, not that rare. We have seen at least 2 or 3 cases, patients with diabetic neuropathy coming up with all the symptoms of obstruction, but not very common. So we will go to the pathophysiology of how the obstruction happens. Might be familiar to all, but I'll just go through it. what happens when there is an obstruction? There is a block. So there is an occlusion of the lumen. So whenever there is an occlusion of the lumen, the bowel contents will not pass. There is a delay in propulsion. So first, the gut has a feeling, okay, there is an obstruction, I have to act, I have to correct it. So it causes colicky peristalsis because it wants to overcome the subobstructive phase. So at this stage, it can be reversible. So there is an obstruction and the bowel is trying to overcome the obstruction. And there will be colicky pain because the bowel is really trying to overcome the obstruction. There will be distension and colicky pain. And at this phase, it can be possibly reversible. So although there is no effect, the bowel is trying really hard to overcome the obstruction, no effect, but still it continues to contract. So when it continues to contract, what happens? There will be uncoordinated peristaltic activity. So more and more colicky pain. And as a consequence, there will be more and more distension because nothing is happening. I'm trying really hard to overcome the obstruction. My gut is really trying to overcome the obstruction. So there is more and more distension and there will be more and more fluid secretion. So this happens like a cycle. More distension and secretion, more will be the obstruction. Again, it is not moving, more secretion, more distension. So this is a cycle of distension and secretion will keep going. And we know that when there is a more obstruction, the contents are not moving. What happens? There will be the bacteria is really interested to come and make a house there. So they'll just come and bacterial accumulation will be there. More and more flora will develop, which will produce gases. So again, gases means again distension because a lot of gases, there will be more distension. And when there is a bacteria, this will produce inflammatory response. How? So the moment you hear inflammation, there will be COX pathway. So there will be increase in prostaglandins and VIPs because they want to eliminate the inflammation caused by the bacterial overgrowth in the obstructed place. So whenever there is an inflammation, we know that there is hyperemia and edema. So more edema means more obstruction. So there is a reduction in the venous drainage from the obstructed segment causing hypoxia because the bowel is hyperemic and edematous and there is a venous obstruction from the obstructed segment which will cause hypoxia. I'm sorry. Yeah. And when there is a hypoxia, there is increase in VIP, which will cause redistribution of blood flow between obstructed segment and other sites. There will be complete redistribution of blood flow. This will cause multi-organ failure, hypotension at later stages. I hope I'm clear. So initial phases, there will be a slight obstruction. The bowel will try to overcome by continuous peristalsis. Even if it is not possible, the bowel will keep trying to overcome the obstruction. But there will be more distension and more secretion. It will become a vicious cycle. So when the obstruction is still there, the bacteria will come and accumulates there, which will produce more distension. And the bacteria will produce gases and there will be gaseous distension also. And as a result of bacterial colonization, there will be inflammation. Inflammation can cause edema and hyperemia of the intestinal segments. And this will cause hypoxia because of venous drainage obstruction. And later stages, it can multi-organ failure or hypotension. So what are the consequences of obstruction? There are metabolic and septic consequences. There will be hypovolemia, which can cause renal failure due to decrease in renal blood flow. Metabolic disorder in malignant bowel obstruction depends on the site and duration of obstruction. So what all metabolic issues will come depends on the site and duration, how long the obstruction has been there. So in a high level obstruction, metabolic alkalosis, as I mentioned in the slide, hypochloremia, hypokalemia is very commonly seen in a high level obstruction. When there is an increase in abdominal distension, the abdomen is very well distended, which will elevate the diaphragm. So patients will have difficulty in breathing and decrease in pulmonary ventilation. And there will be passage of toxins and intestinal contents into the systemic circulation. So at later stages, you might be seeing sepsis, and it can even give rise to perforation at later stages. So these are the metabolic and septic consequences. So this is one thing that we need to remember. Higher the obstruction, more symptoms and less signs. Lower the obstruction, less symptoms and more signs. So the signs and symptoms really depends on, this is one thing that I want you to focus. Pathophysiology and all we can remember when you start seeing the patients, but this is very important in terms of management. What are the signs and symptoms? It depends on the site of obstruction. So I think for last 8 years, I have been using the same example whenever I talk about bowel obstruction. So I'll use the same thing because it has helped me a lot in managing or understanding what the patient is telling. So imagine a wash basin block in your home. The wash basin, depending on the site of the block in the tube, outlet tube, the condition will vary, right? Suppose the wash basin is blocked at the opening, right at the place where you wash your hands, right at the outlet. What happens the moment you start washing the hands? The water will accumulate because it is just there. Something is stuck there at the outlet itself. So the moment you start washing your hands, the water will come up, and it is not that foul smelling because it is really fresh water. You just washed your hands, and you know that early that there is some problem, there is a block there. So same thing with the GI tract. In the gastric outlet obstruction, whenever you drink and the patient drink and eat, early and severe nausea and vomiting because the contents are not moving down. So there will be early nausea and vomiting, and usually the vomiters will not be that foul smelling. Usually they say, I had a cup of tea, and immediately after that I vomited exactly the same cup of tea. What happens in small bowel obstruction? So again, go back to the wash basin example. Suppose the block is at the place where the exit outlet is there in the wash basin. So you keep washing from morning till night. You don't know that the wash basin is blocked. We keep washing, and it very often happens at your home, right? We keep washing, and by night when you are ready to go and settle down in the bed, now we realize that everything is coming up and there is a foul smelling accumulation of water and waste materials, and then you realize that okay, there is some noise coming out from the tube, and the volume will be really less also, usually. It will be like continuous seeping of fluids. So what happens in small bowel obstruction? The patient will keep eating or drinking in the morning time, and they tell you, I had breakfast, I had lunch, I did not vomit. The moment I took the dinner, I started having vomiting, and I vomited everything out. And sometimes they tell you, I think the dinner I had some soup, I think I didn't like it, that is why I vomited. So this is one simplest way to remember the signs and symptoms in high level obstruction and low level obstruction. So in large bowel obstruction, the symptoms appear really late. You will keep washing your hands till night. You don't know that the tube is blocked. And we know that what happens, there is a lot of noise coming from the tube. So there can be continuous, considerable amount of distension. And you know that the water remaining there in the tube, so there will be more of bacterial overgrowth. So it is same thing happens in the GIT. The symptoms appear later. Patients will tell you considerable distension, and there can be diarrhea due to bacterial overgrowth. Can be two types of pain. If you ask the patient, they may say a background continuous pain, which is there all the time, and in between, especially when I drink or eat something, a crampiform pain will come in between. So there is a continuous background pain along with an intermittent cramp-like pain. And the second symptom, so first symptom was pain. The second symptom is nausea and vomiting. So in large bowel obstruction, we know that the wash basin tube is blocked very well down. So the water coming out will be foul smelling. So in large bowel obstruction, there can be feculent, or they may say it was very foul smelling, greenish colored, when they may say it was very foul smelling, we couldn't stand so very importantly, you have to ask, did it smell like a fecal matter? And small bowel obstruction, we know that gastric outlet obstruction, it is more of biliary vomitus, and as I said earlier, I had some tea and the tea came out immediately after drinking. Constipation is a third symptom. There's a pain, nausea, vomiting, constipation. Very specific question to be asked, along with the history of constipation. Are you able to pass gas? We have to check whether he's passing flightus. If the flatus is not there, stool and flatus both are absent, that means probably the patient is in complete obstruction. Always listen to the bowel sounds, whether it is increased or whether it is decreased. So all the symptoms are mentioned in a table. It is easy for you to go through it and recollect. So there are two types of pain, a continuous pain and a colicky pain. So what happens in a proximal obstruction? The symptoms will appear early. We know that the moment you wash your hands, the water will accumulate. Early symptom, and there will be pain in the periumbilical region and short intermittent cramps. And in distal obstruction, late onset of symptom, long intervals between the cramps, and generally they say deep visceral pain kind of symptom. They can't actually point in periumbilical pain. They can't point exactly where they have pain. Vomiting, large amount, usually watery or bilious, and there won't be foul odor. But in distal obstruction, the amount will be small because there is continuous leaking. Gradually, the fluid is building up, and there will be a lot of particulate. You can't recognize what is coming out, and there will be foul odor because it has been accumulating the whole day or maybe for days. Distension of abdomen may not be that prominent in a gastric outlet obstruction, but there will be considerable distension in a distal obstruction. Constipation may not be present, may be present in the proximal obstruction, and sometimes they may say it is okay, they have bowel opening, especially in gastric outlet obstruction. But in distal obstruction, the constipation will be long standing. It may be present up to 1 to 2 weeks. It is rarely an emergency, and your goals of management, it should evaluate the over. We should understand where exactly in the disease trajectory the patient is in, understand the goals of care, whether it is an advanced malignancy, should I recommend surgery, should I go for interventions, or should I just manage conservatively. So we need to know whether which stage of the illness trajectory the patient is in, address the symptoms like pain, nausea, vomiting, constipation, and distension. If needed, you can do investigations for electrolytes and check for hydration. So this is the one of the easily available investigation, and it is very reliable also. X-ray erect abdomen. So we know that multiple air fluid levels are very visibly seen in X-ray erect abdomen when the patient is having a obstruction. In plain X-ray abdomen, proximal obstruction, usually we may not be seeing a normal X-ray, but when the obstruction is distal, we can see dilated loops or multiple air fluid levels. It's quite good in ruling out bowel obstruction, available in all the settings, so it's not that difficult. But CT is the useful test, especially contrast enhanced CT, so that we'll know the extent, the site, how far the infiltration, the type, everything. But we generally do not come across taking a CT scan for obstruction, because if you don't have anything to offer other than what you are doing, then there is no point in investigating more. You know that the patient is in advanced stage, you don't have anything to offer. But there are different other scenarios where the patient is presenting with this symptom, and you really need to understand whether it is feasible for surgery or whether you want to offer some other treatment. Then definitely we would recommend CT scan. But if we know that we expected obstruction, we know that this is an advanced illness, then if it is not going to help you in any way in changing your treatment plan, then but CT is the investigation of choice for understanding bowel obstruction, because we know exactly the area around obstruction, whether there is any adhesion, everything. Management, general management, everything starts with good oral care, good hydration of the mouth, take 6 sips of fluid. As sir mentioned, bowel obstruction means NPO. In whatever patients being referred to us, they come with NPO, and the caregivers are in really great distress that unable to have a sip of fluid. They ask for sip of fluid, but they can't because of continuous vomiting, and the patient is dying. We know that, but he's unable to take even a sip. So that is a real trauma for the caregivers also. So subcutaneous fluids are recommended when the patient is at home for a long-term management, because we are not trying to correct a dehydration, but we want to maintain the hydration. If the patient is dehydrated, definitely IV hydration. Choose the route of administration, whether you want to give IV or subcutaneous, or which route you want to. To reduce the pain, the commonly used drugs would be opioids, steroids, and antispasmodics. We need to check which route opioids to be given. If the patient is continuously vomiting, think where opioid is getting absorbed and where is the obstruction. Then accordingly, you need to decide on the route of opioid. Steroids, the commonly used steroid is dexamethasone, 8 to 16 milligram subcutaneous, up to 24 milligram in some of the literatures, but the usual effect is seen anywhere between 8 to 24. Subcutaneous, we give 3-day trial. I don't know whether it is mentioned, dexamethasone is to be given as a single dose. It is a very common practice to give dexamethasone 3 times a day. And you need to think how, why should we give 3 times a day? Dexamethasone is the longest acting steroid. It has a duration of action anywhere from 24 to 36 hours. Then splitting the dose doesn't make any sense. And at night, it can cause insomnia also with this dose. So it's preferably to be given before noon, at least before 3 p.m. in the evening. Start with dexamethasone 3-day trial. So your intention is to reduce the bowel wall edema. So we are trying to reduce the peritumor edema, and thinking that, okay, the tumor has reduced a little bit, we have some space, then try a prokinetic. So trying to reduce the block by moving, making some space with the dexamethasone, and then give a prokinetic. The usually used prokinetic is metoclopramide, and this is a commonly used dose of metoclopramide. Uh, Ask whether, the very important thing in managing bowel obstruction, the moment you give a prokinetic, monitor the patient closely, ask them whether they have a colicky pain. If they are telling that my colicky pain increased after giving the prokinetic, that means the patient can be in a complete bowel obstruction. You have to stop the prokinetic. So you reduce the edema, made some space in the GIT, and you tried to push the contents by using a prokinetic. Complete obstruction, if it is not resolving and the pain is increasing, then you have to completely focus on treating the symptom. Reduce the vomiting, that is it. You cannot bypass things. You have to accept that it is over. The bypassing effect or mechanism is over. You have to manage the patient, just focus on symptom management. Then the drug of choice would be hyacinth butyl bromide. Infusions, we give 24 hours continuous infusion. And understand the oral bioavailability of hyacinth butyl bromide. The common prescription will be Buscopan. It is, the oral absorption is, I think, around 10%. So there is no point in giving oral medication. And anyway, the patient is vomiting, might be vomiting also. So subcutaneous route is what we do, or intravenous, 40 to 240 milligram. 240 would be the maximum dose. Ranitidine infusions are proven to be useful in reducing the secretions. So all these will reduce the secretion. The gut is basically paralyzed. The gut is not moving. So you should not look for managing the constipation then, because we know that we have given everything to silence the gut down, and we are drying up the secretions. We are making everything paralyzed. Another commonly used drug is octreotide, and it has multiple actions. It decreases the secretion, decreases the mobility, and it is mainly used in high volume vomiters. Not that effective as intermittent dose. It has to be given as continuous subcutaneous infusion. The recommended dose is up to 800 microgram per day. The textbook says 100 to 600, but some other literature say 100 to 800. But there is a very, it's a very commonly used drug in many settings. And there is a very good randomized control trial comparing octreotide and placebo, and they found that octreotide is not even compared, like both has, it is not superior to placebo. So there were many criticisms for that study, but this is one of the commonly used drug in managing bowel obstruction, and specifically for high volume vomiters. It is expensive, so we really need to think whether it is going to be beneficial for the patient. Nausea and vomiting, if the prokinetic, we know that in complete obstruction we cannot give a prokinetic, so then we have to use a centrally acting drug, which may be haloperidol or promethazine. And we know that in partial obstruction we need to try gentle rectal measures and a little bit of softeners and stimulants. But in complete bowel obstruction, it is not, doesn't make any sense to attempt for managing constipation, because we have paralyzed everything, nothing is moving, and then we cannot anticipate expect about movement. These are the surgical options, but most often the intention of these surgeries are palliative, just to improve the quality of life, not for disease modifying management. These are other interventions that is commonly used: NG tube insertion. uh, I've written in green, it should be a temporary measure, just as a venting of gastrointestinal secretions, not for feeding. You have to be really careful. The moment you put in the tube, the caregivers will want to feed, and most often we find it very easy to put in a tube there so that we can keep draining. But you have to be really cautious about that. It has to be a temporary measure, and ask the patient whether the patient is willing to put the NG tube. It is also an intervention. Interventional treatment, there are many interventional treatment like venting gastrostomy when the patient is unresponsive to medical management. If you have access to gastrosurgeon who can take up advanced palliative care patients just for improving quality of life, you can always try for venting gastrostomy. But we know that most often patients come to us with a lot of ascites, previous multiple surgeries, diffuse cancer, and abdominal wall edema. So all these conditions, we cannot give a venting gastrostomy. Stents, I don't know how many surgeons are there. Generally, all of them agree to that. Me when I say this, it is not some of the favorite treatment because failure rates are really high with stenting. But it can be used only when there is a single site obstruction because it helps to reduce the edema and relieve the obstruction. TPN, the role of TPN, very commonly used management in an acute setting. Uh, the TPN is justified in patients with minimal tumor burden. If you are anticipating the patient is going to undergo surgery within 2 days and you really want to make him better, you want to give him nutrition, then it might be an option, but not for an advanced illness palliative care patients, because people think that this is something which can help the patient to become to create some miracle, because it's highly very expensive, and some white color thing is going from a big pouch. Patients will have a lot of hopes in TPN. It is damn expensive, they may not be able to afford it. So offer it only if you are looking for a good life expectancy, and there is some definitive treatment that you are going to give immediately with a good performance scale patients with good performance status. And the summary, one thing you have to understand which area of disease trajectory they are in. Set the goals. What is your intention? You are not going to remove the obstruction. Tell them that what you're going to do, how aggressively you need to look into it. Address the symptoms very well: pain, nausea, vomiting, and constipation. Choose the route of administration. And usually, without any intervention, patients and families can be made comfortable. That is what we have been doing for years. They feel a lot comfortable with all these medications itself. You may not need to give a definitive surgery all the time. So these are some of the references. I know that there were two topics I was slightly rushing to finish on time. I think we have 5 minutes to take up any burning questions.
Yeah, thank you, Sreedevi. Any questions? Anybody?
Yeah, one question.
Yeah.
Regarding this managing bowel obstruction, before starting the prokinetic, it's like, should we manage them first with steroids for 3 days and then only start prokinetic, or we can do both together?
So we start with the dexamethasone usually at the same day we start with the prokinetic also. But very importantly, you have to ask or tell the patient to report to us, or maybe you can try one single dose of, before starting the continuous infusion, you give a single dose of metoclopramide initially, and ask the patient whether it is giving a colicky pain or something, and then if it is okay, patient is telling no pain or anything, then you can give it as a continuous infusion. You don't have to wait for 3 days essentially.
And about constipation in this people with like stroke, motor neuron disease who are being bedridden, for most of them have this constipation as a part of this stool infection. So once you do an enema, you clear it off, they'll be okay. But again, after a week or two, again they have the same symptoms. So what do you suggest in that, like a prolonged a prolonged laxative stimulant? What should be?
Uh, so keeping apart the medical knowledge that we have, I think from a caregiver perspective, okay, if I have a bedridden patient and with a neurological issues who have constipation, I would be giving fixed days, for example once in 3 days, every third day I would be keeping suppository, and the timing would be when I have time to clean it up and make the patient, like clean the patient very well. That is how I would think, because the caregiver, the patient might be better and may not be able to manage bowel everything on their own. And if you give continuous laxative, very often patients will find it difficult because there will be an urge and the caregiver will not be at home in the morning time, so they may not be able to take care of everything. So maybe at least once in 3 days, if you can teach the caregiver to keep a suppository. Uh, After my job, my children are gone to school. Now at 10 o'clock, breakfast is over, or just before giving a bath. So I'll give suppository, and patient will have and make him sit on a commode chair if possible, and then give the bath, clean up everything. So that is good in terms of long term. The illnesses that you mentioned is going to be a long term issue, the MND as well as any other neurological issue. So the caregiver also has to be in ease rather than giving choosing the laxative, which stimulant or softener. I would think from a patient and the caregiver perspective.
Thank you. That answers the question.
Thank you. How often do you come across the issues with constipation? Do your patients ever tell you that I'm constipated, or did you have the practice of asking or exploring more about constipation?
Actually, most of them complains it. Actually, I feel like they find it. Sometimes we may feel maybe he's saying why they are much concerned about a constipation. Let it be. Sometimes they get that feel because they take it as a very important complaint. Most of them.
That was a question to everyone also. Someone typed in the chat, almost every day they see constipation. How do you use this Bristol chart? So the way I use, ideally you can use the chart. If you are in an IP setting, you can use the chart and ask and document the type of stool. We don't do that for every patient, but what I personally practice is when you go for home care or you are seeing a patient in an IP, they may not be able to tell you exactly how the stools were, or they may be slightly reluctant to tell you that it was like nuggets or comparing it with something. They have slight embarrassment. So when you show this, take this in your mobile, that picture, and ask how well you which picture you can relate to. So they may tell you, okay, it was like this. Then they'll be they'll be so relieved that they don't have to explain exactly how did it look. They can just point which picture is closely related. Senna, someone has asked about Senna tablet. Senna was available a long back, and I'm not sure Senna is available now. But Ayurvedic preparations, there are a lot of Ayurvedic preparations which has primarily Senna in it. But am I right, Dr. Sunil, about Senna? Yeah, Tribhala and some of the any Kayam tablets has the content of mainly Senna in that, but not available in our.
I think I'm not very sure about is it available now, but I was just searching for Senna tablet.
It is
It
not
was
available
available. It
prescription
was available.
these days.
Yeah.
Now it is an Ayurvedic preparation you will get everywhere. Kayam Churnam. I very accidentally came across that, and when I looked at the content, it is Senna. So it is basically stimulant, and it is the recommended drug for opioid-induced constipation. But it was available long back. I heard Dr. Rajgopal telling, but these days, no.
Excuse me, ma'am, one question.
Yes, sir.
Uh, the patient is when we give the tablets and some syrup for the constipation and everything is good, but every time they have some psychological or something that stool is not clear. What should we do?
So if the patient is telling that, that means the stool is not clear. Irrespective of giving all these laxatives, we still have a lot of patients not having bowel opening. The maximum dose of stimulant, maximum dose of softener, patients will still tell you that they have some issues. It is not satisfactory. So that is quite possible. Then you have to ask exactly what is the difficulty. Is it more like a hard stool? Can we do something about their diet? Do they need a regular like regular schedule of suppositories if they have inadequate bowel opening? That is also very common practice. People tend to keep suppositories, as I mentioned, every third day. They keep suppositories because with maximum dose of laxative also, people find it very difficult to open the bowel. So that if the patient is telling you that, that means they have that issue.
Thank you, ma'am.
Any more questions? So I think we will move on to a patient story. So I think uh, one participant who was supposed to present the patient story was unable to present today. So there were no patient stories. So I will be presenting a patient story. Arun, can you enable me to share the screen?
Yes, sir, you can.
One minute. Okay. So our patient is a 67-year-old man who was diagnosed to have carcinoma lung recurrence, and he also has diabetes mellitus, hypertension, and previous history of coronary artery disease. So his main problem was pain, which is of 2-month duration, and you can see the site uh, on the front of chest at localized area. He described it as a continuous catching type of pain, which severity ranges from 4 to 8/10 without any radiation. But it increases when the patient sits up or walks or during the movements, and it decreases by lying down in a particular position. So because of this pain, he is unable to sit or walk or unable to eat, and he's not interested. And he described it as he is dejected. So the history of illness in January 2009, patient had cough, hemoptysis, voice changes, and he consulted a nearby doctor and advised CT scan, which uh, showed a mass in the right upper lobe with collapse, and it was diagnosed as carcinoma lung with a biopsy. The patient was advised to undergo surgery, but they declined because he didn't want to undergo surgery considering the complications. So the doctors advised him for concurrent chemoradiotherapy, and he finished it. And he was okay, but after some time his general condition started deteriorating in early 2020, and it was diagnosed as having carcinoma of the lung recurrence. He again underwent chemotherapy and immunotherapy, but in 2020 January, sorry, 2021 January, he was admitted with worsening of pain and deteriorated general condition. So the oncologist stopped all the oncological intervention and told them nothing is possible at this stage. And um, because of this severe pain, they did an intercostal nerve block probably. We don't know what nerve block was done. We assume it was an intercostal nerve block. And then he was admitted here with pain, loss of appetite, and he was not interested in anything. He is not interested to talk. He is not interested in any activities, and he was also hopeless. And on examination his vitals was normal, blood sugar was under control without any medications, and all the systems were within normal limits, and the area where the pain was there was tenderness. And regarding the psychosocial aspect, he lives with his wife, and they have no children. He's an advocate, and wife is a retired principal from a school. Uh, so both of them have siblings, but they live far away, and all of them have their own responsibilities. So the siblings, they don't come frequently, and wife says we support each other. An insight of the patient and wife regarding the diagnosis and prognosis is, patient was telling that we asked what did the oncologist told. So he told that oncologist told me that you are in a danger situation. So, and he understand that his disease is progressing and any oncological interventions are not possible at this stage of the disease. A wife also understand the diagnosis and prognosis, and during the admission time, he actually donated a piece of land for an institution where they are going to build a place for staying the cancer patients. So patient was allowed to go for that foundation stone laying, um, and he was very happy, and they have no financial problems. They are very well off. So the patient actually, when he was admitted in another hospital, he was on 20 to 30 milligram of morphine 4 hourly and SOS. So he had delirium, myoclonus, and drowsiness with that. So they stopped morphine and gave him nerve block. So that's what I described as intercostal nerve block probably. And he was put on fentanyl patch 25 microgram with a 10 milligram of morphine SOS doses. And he used to take about 5 to 6 doses per day. And he was also getting tap pregabalin 75 milligram HS. So we have a 67-year-old man who has pain in the front of right chest, which is catching type of pain, continuous, which ranges from 4 to 8 by 10. And he is on fentanyl patch as well as morphine SOS without satisfactory pain relief. So how will you manage his pain? So anybody can comment on this? Anybody?
The synthetic opioids the morphine, fentanyl, and like the neuro pain management, the pregabalin, all those things was given. Apart from that, what else? Nothing.
Okay, so fentanyl patch will take time to act. Yeah, Dr. Bismi. Yeah, that's correct. But he was on fentanyl patch for the last 2-3 weeks. Is fentanyl a good drug for unstable pain? So, what are your opinion? So, Dr. Bismi is asking, meanwhile, shouldn't he receive something more? Okay, so when you start fentanyl for the first time, then it will take about 8 to 12 hours to act properly. So during that time, we have to give some medication. But here in this patient, he was on fentanyl for the last 3 weeks. Is fentanyl a good drug for unstable pain? Anybody? I am unable to hear any comments. Okay, Dr. Mahesh says, can we use methadone? Fentanyl is, Dr. Jaina says, fentanyl is not suitable for unstable pain. Yeah, that's correct, Dr. Jaina. Fentanyl is not used for treating unstable pain. Dr. Radha says, can we use ketamine? Should we increase morphine dose and give it regularly? Yeah, that's an option, Dr. Stalin Vijay. But when he was on 20 milligram of morphine 4 hourly, he had toxicities of morphine. So probably he is going to have that toxicities too when you increase the dose of morphine. Yeah, amitriptyline. Yeah, that's a choice. Amitriptyline can be used. So, Sreedevi?
Sir, I think this patient, they should answer because yeah.
Okay. Yeah. Okay. Okay. I just asked you, that's all. So, I would like to actually show you how to convert a patient from morphine to methadone or from opioid to methadone. So in this patient, we can use methadone. Okay. So how will you convert a patient from another opioid to methadone? Yeah, we can repeat nerve block. That's what Bismi says. Can be, but that nerve block was not very much helpful. Okay, so first of all, we have to calculate how much morphine he was receiving. So this patient was getting 25 microgram fentanyl patch, which is equivalent to morphine 60 milligram tablet per day. And he was receiving 5 to 6 SOS doses of morphine. So that will come to 60 milligram of oral morphine. So total, he was receiving 120 milligram of oral morphine. Anybody remember what is the conversion rate if from morphine to methadone? Okay. Okay, so this is the conversion ratio. If the patient is taking less than 60 milligram of oral morphine per day, then you can use 2 to 7.5 milligram of methadone per day. And 60 to 199 milligram oral morphine equivalent. And if the patient is less than 65 years, then you have to use 10:1 ratio. And if the patient is taking more than or equal to 200 milligram, and bar or patient is above 65 years of age, the conversion rate is 20:1. So what is the conversion ratio here in this patient? What is the conversion ratio here? Ten is to 1. What is the age of this patient? He is 67. Okay, so look here, 60 to 199 morphine equivalent, and patient is less than 65 years, then you can use 10:1. But if the patient is above 65, you have to use 20:1. Yeah, 20:1. Okay. So our patient is on 120 milligram of morphine and he is 67. So that's above 65. So the conversion ratio is 20:1. So you have to divide 120 divided by 20. That will come to 6 milligram. So we started this patient on 2.5 milligram BD. So next day he had better pain relief, but on the 6th day, his pain score was 2/10. And there was no toxicities of opioids. He says previously when he was on 20 milligram of morphine, he was seeing bad dreams. Somebody is coming and trying to kill him, and seeing some insects, etc., etc. So he had frequent myoclonus and he was drowsy all the time in bed. On methadone, he had no toxicities. He didn't had any incidental pain. Sorry, he had only incidental pain. So we increased the dose to 2.5 milligram TID. And now it's second day after increasing the dose. So the patient is unable to sit up for 10 minutes without pain. He has improved appetite. He is interested to talk. And wife was telling us that previously he was always talking about death, but now he says he told the wife that all the relatives are expecting me to die, but I am not going to live. So he has a positive approach now. So this is how you can convert an opioid into methadone. And you have to before you do conversion, you have to also see, you have to actually inquire first about is there any history of sudden unexplained death in family, because torsade points which can cause sudden death can cause sudden unexplained death which runs in families. So you have to get a history about this from the patient, and if possible you have to check the corrected QT interval. So QTC has to be calculated if possible. Um, then there are many medications which can interact with methadone, and it can either increase or decrease the concentration of methadone in the blood. So the usual medications or many medications which we use in palliative care, like benzodiazepines, um, SSRIs, SNRIs, tricyclic antidepressants, antifungals like fluconazole, um, all these have um, all these have interaction with methadone. So this also need to be checked before starting methadone. So anything else you want to ask from this conversion? Anybody? Okay, okay. Actually, I don't remember all the medications which can cause interaction with methadone, but most of the medications, many antibiotics like azithromycin, erythromycin, fluconazole, tricyclic antidepressants like amitriptyline, imipramine, SSRIs like citalopram, escitalopram, um, antipsychotics. All this can causes interaction with methadone.
So someone has asked about the name of a drug.
Yeah, I think this he was talking about interaction. That's why I explained once more. So, Dr. Mahesh, was you were you talking about interaction? What all medications interact with? Yeah. Okay. Anybody else has? Yeah.
Sir, as we have given the methadone, that the pain score is 2/10. Should
Yeah.
we increase the pregabalin dose, means 75 BD or something, so
Okay.
we can achieve
Actually,
the?
yeah. Actually, we stopped pregabalin because pregabalin also cause interaction with methadone.
Okay.
Pregabalin, gabapentin, all those interact with methadone.
Okay, thank you.
Anybody else? Anything?
Sir, if not, can we wind up our session? We have another training coming next.
Okay. So thank you, Sreedevi, for being with us for another session.